Welcome to our PID class. I hope you're doing well. Today we are going to look at a broad topic, broad in such a way that etiologies of this condition tend to lead us into other pediatric topics. So, neonatal seizures. Under this topic, we are going to look at the following outline: the definition, prevalence, classification, etiology, diagnostic approach and investigations, management, and finally, differential diagnosis. So let's dive in. A seizure is a paroxysmal behavior caused by hypersynchronous discharge of a group of neurons in the brain. They are a medical emergency. A reminder, neonatal period is a period from 0 to 28 days. So in the early neonatal period, that is from 0 to 7 days of childbirth, and then late neonatal period is from 7 to 28 days. In the prevalence, we should note that over 10, in other words, these neonatal seizures are over 10 times higher in preterm newborns than in term babies, and then 80% of neonatal seizures occur within the first 1 to 2 days of life. 50% of neonatal seizures are subtle, self-limiting, and non-pathological. The classification, we classify them into 4 groups. We have the subtle, the tonic, the clonic, and myoclonic. Though these classifications depend on different texts, but in our class series, we're going to consider this classification. So let's look at each of them. Subtle, they are especially seen in preterm and term infants. Clinical manifestations are mild and can frequently be missed. Usually mild paroxysm, alteration in motor, behavior, or autonomic function. The major thing to note here is you can easily miss the seizures because the clinical manifestations are so mild. It might be just a slight movement, rapid movement in the muscles of one eye. Then the second classification is tonic. These primarily occur in preterm babies and they are characterized by flexion or extension of the axial or appendicular muscle group. This word should not confuse. The axial skeleton is a main skeleton, consists of the chest, the spinal cord. Then the appendicular muscle or skeleton is these long bones that join to the main skeleton. So you have those muscle groups. And then these seizures can be focal or generalized. So let's look at, and then here also there is no use of EEG because there is no alteration in brain activity in this type of seizures, whereas in the following type of seizures, which is clonic, these primarily occur also in neonates. The rhythmic movement of muscle groups, you notice 1 to 3 jerks per second, and they are associated with EEG changes. This is a difference. The other group, there was no change in the brain activity, but here there is change in brain activity. Then let's look at the last group, myoclonic. Myoclonic is like clonic seizures, but the difference is here the jerks, the movements are rapid. The movement of the limbs, they are so fast, as noted here in our slides. And then Yeah, this statement line goes to highlight more about them. There might be single or multiple fast jerks of the upper or lower limbs, and then myoclonic jerks are more rapid in speed compared to clonic seizures. Then in the etiologies, there are those etiologies that occur in the early period, early neonatal period, and these etiologies that can cause seizures to occur in the early neonatal period. These include birth asphyxia. In this, you have compromise in the ability of the child to breathe in. Therefore, the brain doesn't get enough oxygen needed for metabolic activity, hence triggering a seizure. Then you also have hypoglycemia. The brain is not receiving enough glucose needed for its metabolic function. Then you also have dehydration, usually secondary to bleeding. This can occur due to lack of vitamin K that can cause the bleeding to occur. And then also, it can also cause, because if there were some interventions that were done during birth, like instrumental delivery, that caused abrasions on the skin of the child, exposing the child to risks of bleeding, and hence can bring about dehydration and can bring about a seizure. And other causes of dehydration, of course, we have electrolyte imbalance, metabolic acidosis. In electrolyte balance, should note that these are required for normal transmission of impulse. No sodium is required. So if there is imbalance in those ions, they can bring about a seizure. Then you have metabolic acidosis, hypocalcemia. Then in the late period, you can have hyperbilirubinemia. Bilirubin rises in the body. This can be caused by hemolysis. Anything that triggers hemolysis can be infection. The major cause is ABO, blood group incompatibility, that can trigger hemorrhage. They have fluid and electrolyte imbalance. This includes dehydration. Congenital CNS abnormalities also can trigger seizures. Then CNS infection like meningitis, septicemia, then viral encephalitis. This virus, some of them can be transmitted from mother to child, like cytomegalovirus, that can later infect the child, cause encephalitis, and trigger a brain when neonatal seizure. Then you have toxoplasmosis also can trigger. All right, let's look at the diagnostic approach. Here, trying to find out the cause of the seizure. So you can start with the seizure history. Were there any noticeable changes before the seizure? And then what about after the seizure? Were there, how was there complete recovery or gaining of consciousness after the seizure, or there was a slight period where there was no complete gain of consciousness? Also, the condition surrounding the seizure, was there increased blood temperature, was there infection? This can guide us to identify the cause. Then also we have to look at antenatal history. In the antenatal history here, we are going to look at the condition. We are trying to rule out the condition that must have compromised the baby when the baby was still in the womb. For example, maybe there was infection. You see, maybe there was condition like you have conditions like malaria. You have conditions like maybe accident. May you have conditions like low low we have low amniotic fluid that also impaired the development. And then you also have even insulin, I mean the diabetes in pregnancy. Then and all those conditions. Then we look at prenatal history, the condition that surrounded childbirth. This was there prolonged labor, Was there instrumental delivery? Was there hemorrhage? These are the questions we're trying to ask to rule out the different causes of neonatal seizures. Then also feeding history. As we noted, hypoglycemia can be the cause of a seizure. So that's why we advise that these children should be given, these neonates should be breastfed within the 30 minutes from the time of delivery. We are trying to prevent a seizure that can come due to hypoglycemia. Then family history. For example, this we have epilepsy. There is a possibility of a neonate having an epilepsy because there was a mother or any of the first degree relatives that have a history of having epilepsy. Even febrile seizures, as we discussed in another topic, there is a genetic aspect. Then let's look at the investigation. These investigations are trying to rule out the different etiologies that you have seen. For example, blood glucose levels, incomplete blood count, bilirubin if jaundice is clinically present, arterial blood glucose or blood gases, cerebral spinal fluid examination, and then electroencephalography. Here, you should note that it's not a must that you should do all these investigations, but investigations are tailored to the probable cause of the infection or of the seizure, depending on the history that you are getting. And here, find the baseline investigations that you should do, like complete blood count, then blood glucose levels. You start from there, and then arterial blood gases. You start from those baseline. Then the rest of investigation are going to be tailored. For example, bilirubin levels in blood. You're checking blood serum. You're checking if there are clinical features of jaundice. Jaundice is the yellowish discoloration of the mucous membrane. So you can look at the palm. You can look at the lips. You can look at the tip of the nose. Then also cerebrospinal fluid examination. This also can come in if there are signs of meningitis, that is meningeal irritation, that can also trigger or can necessitate that you carry out examination of CSF. Okay, so also screening for congenital infection. This can also be obtained from the history of the mother. She told you that she had suffered from a certain infection that might have been transmitted to the child. So you also screen the child for those infections. And then imaging can also be done, as this can reveal different abnormalities in the brain. Like CT scan can help you identify in case there is hemorrhage, and this hemorrhage is triggering a seizure. Then assessment and management of convulsing neonates. Here you have three major objectives. You have to prevent airway complication. That's why you have to reposition the child in such a position, such a way that there is nothing blocking the airway. Then you also remove any secretions. You can provide artificial ventilation. Oxygen can be provided by nasoprons, and also in some kind of condition you can do intubation. Then you prevent brain damage by stopping a seizure, as continuous seizure brings about continuous brain damage. So you should aim at immediately terminating the seizure with the anticonvulsant of rapid onset, that's diazepam. Then you have to look at the definitive treatment. This is accompanied by or entails with identification of the cause and treating the underlying cause. In case it's hypoglycemia, you give dextrose. And then this is another objective: prevent intravenous hemorrhage. Like we've said, it can trigger seizure. So here routinely we administer vitamin K to all babies on immediately after delivery to prevent hemorrhage. Here the liver of the child, of the infant, is not developed and cannot manufacture enough vitamin K needed for other maturation of other clotting factors. So you're trying to provide artificial vitamin K. All right, let's look at the management. You have the ABC: airway, position, suction, ventilation. That's what you do. Then you have cardiovascular function. Check the pulses. You also check for any signs of hypovolemia, and here hence you replace the fluids. Because there are signs of hypovolemia, you replace these fluids. Then you have to give a rapid acting anticonvulsant, diazepam, to terminate the seizure. Then you treat hypoglycemia if it's there with dextrose. Then you give vitamin K. Prevent hypothermia. Hypothermia can also trigger seizures, so you cover the seizure in warm, clean clothes. And then you do relevant laboratory tests, the baseline, and also those that can help us rule out the cause. So those can include electrolytes, blood glucose levels, you can do blood culture, rule out sepsemia. Then also prevention of repeat seizures. This is very paramount. You have to ensure that seizures do not occur again. In case the cause was a febrile seizure, it was a febrile seizure and the cause was increase in temperature, you make sure that this doesn't reoccur. So these are the commonly used anticonvulsants. They are in three groups: benzodiazepams, phenobarbital, and then phenytoin. Alright, let's look at the differential diagnosis. Some of these have been highlighted already: hypoglycemia, hypothermia, hypovolemia, asphyxia, anemia, intracranial hemorrhage, sepsis, congenital abnormalities. These all have been listed, and we have tried to look at each of them and how they trigger a seizure. I will discuss each of these in my different subsequent lectures, so stay tuned. Otherwise, in case you like the video, thank you very much for watching. Hit that subscription button, hit the likes, and you can recommend a friend. Otherwise, enjoy your day. Meet you in the next lecture.